Before we get started on today's episode, a quick introduction to VitalStream. VitalStream is a wireless wearable, non-invasive hemodynamic monitoring platform designed to give continuous real-time physiological data so you're not relying purely on intermittent cough readings when patients are unstable, moving or in a non-traditional care space. So it uses AI algorithms and patented post-decomposition analysis to continuously measure blood pressure and advanced hemodynamic parameters such as cardiac output, stroke volume, systemic vascular resistance and fluid status, helping teams understand whether a patient is fluid responsive and what's driving the physiology. BHA Medical's VitalStream solution focuses really on getting that continuous non-invasive monitoring into acute care workflows, streaming real-time data to centralized platforms so clinicians can make earlier, better informed decisions. And for corridor medicine, where patients can end up in areas without usual monitoring infrastructure, the key issue here is misdeterioration between spot checks. So continuous trending is the point, reduce blind spots, supporting early recognition of hemodynamic decline, helping teams prioritize interventions when staffing and space are stretched. And for pure spot care, where we're interested in keeping the physiological story visible from first patient contact through transport, VitalStream is designed for rapid application, fit and calibrated and monitoring within 90 seconds with a low pressure finger sensor, so crews can follow trends in real time rather than snapshots. For more information, please head to the show notes or go to bha/medical.com and look at the VitalStream option there on the platform.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're going to be speaking around physiology-guided resuscitation with Mark Faulkner. So in the conversation, we really want to move beyond the idea of simply recording numbers. Instead, we really want to look and explore with Mark around how physiological data can be used to guide resuscitation in real time, helping clinicians both understand what's going to happen next with a patient, also how interventions are working and where we should take potentially resuscitation next. So from cardiac arrest to trauma and shock, physiological signals such as end-tidal CO2, blood pressure, perfusion markers, and ventilation parameters can provide powerful insights into the patient trajectory. So today we're going to examine really how clinicians can move from monitoring physiology to actively using physiology to guide care. And it's also true to say that no number alone bears relevance. It really is about trending the data and looking at the trends and the patterns in the data. So joining us to dissect this topic is a guest who's been on the podcast before, Mark Faulkner. Mark is an advanced paramedic for HIOWAA, so Hampshire and the Isle of Wight Air Ambulance, where he provides clinical leadership through critical care practice day to day. So his work spans frontline clinical practice, clinical education, quality improvement, and the development of clinical pathways that shape how advanced post-spot care has been delivered in the past. Welcome back to the podcast, Mark.
Hi, Owen. Thanks very much for having me back. I should point out to the listeners, I am in week 4 with HIOWAA. So much of what I'm talking about today is from my previous role with London, where I was Associate Clinical Director and Consultant Paramedic. And a lot of what we'll talk about is based on my experience and the work we've been doing in London. So I'm very new, having transitioned down towards the South Coast. But no, thanks for having me.
Oh, listen, it's a pleasure. Absolute pleasure. And I guess if we could just kick off, Mark, and maybe get your reflections and perspective initially, really on how physiological data can help guide clinicians' resuscitation, rather than just simply document what's happening during cardiac arrest and or other time critical emergencies.
Absolutely. And I think it's probably worth us just talking about what we mean by kind of physiological guided resuscitation. And I'm going to spend quite a lot of time talking about the kind of concept of resuscitation in terms of CPR. And if we go back a number of years and we look at some of the eminent papers that were published around sepsis, and we can all spend hours critiquing it, and many of us have, writing essays on the subject when we were doing research methods, and you look at the Rivers paper in sepsis, we very much have moved in very many areas of medicine to looking at physiological guided treatment, looking and targeting our interventions to the patient's physiology. And we can do that really well. And the sepsis data is now absolutely established. There is really growing data coming out of the trauma world. And there's some really exciting work going on from the team at the kind of academic department of trauma medicine in the military in the UK and the team at Bart's Health. and the AI TRIPS program, looking at how can you use AI to predict injury pattern and particularly injury physiology. And that's really exciting work being kind of led by the teams at Barts. But actually, when we start talking about our sickest group of patients, and our sickest group of patients being those in cardiac arrest, how can we really use a physiological approach to monitoring to look at what's going on in that group of patients? And if we go back and we look at Steve Barnard's work, I think in 2024, the group published this, and we kind of know that conventional CPR or conventional chest compressions somewhere produces a cardiac output of 20 to 25%. And it's very easy to say that. But what does that actually mean? It means that we're not perfusing a brain adequately. We're probably developing an increasingly ischemic myocardial infarction, which is even more catastrophic when we realize probably in many of our patients, the cause of that cardiac arrest is already an ischemic myocardium. And our cellular metabolism rapidly becomes unstable. And we're absolutely operating at the limits of physiological viability. And what we have in terms of resuscitation is we kind of have an algorithm, time-based, standardized approach that says put your hands in the middle of the chest, press 100 to 120 times a minute, 5 to 6 centimeters in an adult. But that's not really targeting anything towards the patient. And like many of us, we've all got the index moments of looking at a patient in cardiac arrest who happened to have an arterial line in, realizing that what looked to be really good chest compressions was absolutely producing no flow whatsoever. And I've stood in the cath lab watching this patient who we'd brought in having their umpteenth cardiac arrest. And this time we've got a radial wire in because they were mid-angioplasty, and you're going, we've got great chest compressions. According to the textbooks, they're in the middle of the chest. We're pressing hard, we're fast, we're rotating the person, and we're not creating any flow whatsoever. And what we've now got to start to ask ourselves is, are we even measuring the right thing? Actually, is compression depth, compression rate, chest recall, which are all really evidence-based, and we can look at all of the studies, and there's animal studies after animal study after animal study that says that all of these are really important. But there has got to be something that says, actually, are we pressing in the right place for Mark? And are we doing the right resuscitation for Mark? And we've done lots of stuff, and there's lots of really good devices out there. I can remember, like you, Owen, growing up, and the kind of concept of turning the metronome on in CPR, and nobody liked it. It distracted everybody. But actually, we've got metronomes. We can use Zoll and Stryker both have CPR feedback devices that help you. But what they are telling us is where we're moving our hands through space. What they're not telling us is probably what we need, which is, are we getting flow? And the question we then have to ask ourselves is, what is it that we want with flow? And actually, the key with this is diastolic perfusion. Because if we go back to our first principles, we're not going to get ROSC unless we've got diastolic blood pressure. Because it's during diastole, the heart itself gets its blood flow. So when we start talking about all of this, and we start talking about resuscitation and physiological resuscitation, we're talking about flow. And specifically, yes, we clearly want cerebral flow because our brain is that organ that needs perfusion. But if we want ROSC, we need to make sure we are creating a diastolic pressure. And then we've got to ask ourselves, how on earth do we do that? And how on earth can we target this? So hopefully that's a very long Mark introduction to perhaps what we'll talk about over the next few minutes.
No, absolutely. And to your point, actually, I think there's been a lot more credence and focus on diastolic pressure, like you said, because that does constitute coronary perfusion and coronary blood flow. And actually, it's absolutely essential because, to your point, how can you restart an ischemic myocardium if it's not getting the valuable blood, oxygenated blood that it needs to restart? And I remember you saying, one of the key factors for ventricular fibrillation is an ischemic heart. It will fibrillate if it's not getting the oxygen it needs. But could I get you to just looking at the measurements that we get, there is small inaccuracies, sometimes large inaccuracies in the physiological data. But could I get you to speak to how that can maybe influence us or indeed guide us away from really the direction of treatment, the correct direction of treatments?
Absolutely. And I think the first thing is that non-invasive blood pressure has a role. There is absolutely no doubt that non-invasive blood pressure has a role in pre-hospital care. It's easy, it's quick, you can do it. But your challenge with it is that it only cycles every few minutes. It is massively impacted by movement. Um, if you go back to what is effectively a pressure flow monitor, and that's how it gets it, it's the movement against the pressure of the cuff. I'm not going to insult anyone by trying to explain to how a um, NIBP cuff works, but actually that movement in the back of an ambulance can rapidly deteriorate. And actually, if you look at some of the licensing and some of the user instructions for many of these devices, they tell you that they shouldn't be relied on in a moving vehicle. But it does have a role, and we shouldn't throw the baby out with the bathwater, and we should realize that it's quick, it's easy, it allows us to do it. Um, the If we look at kind of and talk through some of the physiology concepts of CPR, and when we're talking about adjusting chest compressions, thinking about, are we pressing too hard? Are we not pressing hard enough? And actually really targeting that individual's compression to their physiology. Um, we've got to think about how we do that. And if we go back to our first principles and remember that CPR, and you have a cardiac pump mechanism and a thoracic pump mechanism, and during the compression phase, you generate forward blood flow, and you increase the aortic pressure. And in the decompression phase, you allow venous return and enables coronary perfusion. And you come back to that principle, the myocardium is perfused during diastole, not compression. Um, and the probable formula that we've just got to have in our heads is a kind of coronary perfusion pressure, or the CPP, which is aortic diastolic pressure minus the right atrial pressure. And if we have a low diastolic pressure, coronary perfusion is adequate, myocardium oxygen delivery fails, and less likely you are to get ROSC. So if you want something that allows you to measure and target that, that's got to be something different from a non-invasive blood pressure cuff, even if it's most rapid setting, going up and down every 2 to 3 minutes. And yeah, and you go back to, and you will remember this, Owen and I, our background is we're at university together now over 25 years ago, and we had a great lecturer in medical physics who put a blood pressure cuff on a piece of wood and sat there and swung the hose against the table leg, literally on a tree branch, and managed to get a blood pressure of 120/80. And it still sticks with me today that is actually really kind of key, that you've got to be minded that actually this is a device that's measuring kind of effectively a pressure, and you've got to think about how you do that. And probably when you're in cardiac arrest, an NIBP cuff might not be what helps us target. So we know that if we look at the literature, and I've shared with Owen my kind of reference list for this, and I'm sure Owen will stick it in the show notes, that Aziz has done some great work on this that basically says the higher the diastolic blood pressure, the more likely you are to get ROSC. Fact. So we now need a way of targeting that. And Paul Reese's and John Barrett's work, who are colleagues of both of ours, who at EAAA, or were at EAAA when this work was done, have absolutely shown this in clinical practice through the ERICA work, that looks and basically says that their kind of figure was a diastolic blood pressure of higher than 35 millimeters of mercury to start to see ROSC. And what their work kind of told us, well, arterial monitoring is feasible in a pre-hospital arrest. Well, that's in a HEM system with multiple clinicians. Yes, of course it is. It also told us that diastolic blood pressure varies massively in this group of patients, and that ROSC is associated with higher diastolics. And that kind of 35 cutoff is probably where we want to be. But this is the challenge. When you get a critical care response to that patient and you put in an invasive pressure line, an invasive arterial line, be that a femoral or a radial line, both are achievable in cardiac arrest. But they're probably not achievable in the first few minutes of that cardiac arrest. Even if we taught every paramedic in the country to do this, we still wouldn't be in a position where that was being done, and we could target those compressions in the early minutes of that cardiac arrest, where that perfusion pressure is so absolutely vital. And actually, you've got to question, and I say this now working in an air ambulance setting, an air ambulance turning up at minute 20 into the arrest, and that's a good day on dispatch, and putting an arterial line in, you've probably missed the opportunity. And actually, what we've now got to say to ourselves is, if we want to target and look at flow and look at pressure, which is what I think we need to be doing, is putting an arterial line in at minute 15, minute 20 into a cardiac arrest really that helpful? And we should also remind ourselves that actually all of this stuff takes time. And we know from when we looked at the data from the paramedic study, or paramedic 2 and paramedic 3, the time even taken to get intravenous access and adrenaline commenced in a out of hospital cardiac arrest is longer than you would think. I think kind of we're seeing 12 to 15 minutes in those studies, people just get adrenaline by the time you've got intravenous access. And you've got to remember that you've got to put this into the context of that staged pre-hospital response. Perhaps that first person is a community responder who's got no invasive skills. You then get an ambulance crew whose focus will be on early shocks, and absolutely that's appropriate. So by the time you're doing a ultrasound guided femoral arterial access, or ultrasound guided radial access, which is what you'll need to do in cardiac arrest, you're probably at 20 minutes plus before even that gets in, even if those skills sat within a paramedic workforce. So we've got to then ask ourselves, is if we want to look at this, how do we look at this? What else can we do? Well, an arterial line gives us a beat by beat pressure. It gives us a direct measure of diastolic blood pressure, and is probably a really good surrogate in terms of perfusion. But as we've spoken about, it takes time to insert. It's technically quite difficult. You've got to make sure you're doing this without interrupting chest compressions. We clearly don't want to be in a position where we're saying, oh, just pause chest compressions whilst I undertake a femoral stab. We've got to be reminded that some of these patients will be very vasoconstricted, and all of that. Can we do this with non-invasive blood pressure? Well, every 2 minutes, every 3 minutes is probably not ideal. It requires a pulsatile flow. We know that in low flow states and in vasoconstricted patients, non-invasive blood pressure is highly unreliable. So I'm not sure we can. And as an individual who fairly regularly, when I turn up to cardiac arrest, puts a non-invasive blood pressure cuff on just to see what it says, my experience is it virtually nearly always fails. And it probably isn't what we want to be doing to guide that kind of resuscitation. So we've now got to think about, what could we do to do this? What are the emerging technologies? What have we already got? Actually, if we're serious about this, we want this as close to the point of cardiac arrest as we physically can. And we've absolutely got to think about how we do this, because doing it latterly and later on in the arrest is probably missing the opportunity for intervention.
Yeah, indeed, and that becomes a systems issue as well as an evidence-based issue because to your point around how we integrate that earlier on into the arrest, and we will go and look at a few of the more of the physiological data points such as ETCO2 and look at the utility of that. But before we do that, Mark, could I get you to maybe in a way just expand on the element of trended data and you know that no number is that is necessarily useful in isolation, but that we really, you know, it is about that physiological story over time and you know how what's the trajectory, is the patient responding, are they improving, but getting a gestalt, a feeling, an overview of where that patient's moving. Could I get you to maybe speak to that?
So I think whenever we talk about physiological monitoring in whatever group of critically unwell patients, we've got to look at this as more than simply the stamp of a single set of observations. You've got to be able to look at monitoring in terms of trends, changes. The other thing I think is you should always ask yourself is where would this patient be at a point of baseline or point of being well? Um, that kind of um, I I recently attended a patient who had been um, run over, and we had a conversation, and we saw a blood pressure of 110 over 65, and there was a lot of people stood around this patient who was quite reassured by that until you realise that this patient has a body habitus of a lot. They are unmedicated hypertension because they've stopped taking their ramipril because it's giving them a cough. So they're probably at baseline running at 170 over 110, conservative guess. Um, Having seen what their medical records were, they were a lot higher than that at baseline. And actually, you suddenly realize 110 over 61 is profound hypotension for this patient. So actually, I think before we even start at the trend point, you think, where is this patient at baseline? What would we expect good to look like for this patient, or degrees of bad to look like for this patient? Um, and there is some really interesting work now going on about beat by beat blood pressure technology. We know that you can look at early prediction of sepsis from beat by beat blood pressure. You can look at early prediction of deterioration by simply looking at recall and vessel recall um, um, in this group of patients. And once you start to get really good trending physiological data, I'm sure it's going to will help us um, look at patients in a much wider way than we were. Um, and I think one of the things I think's really interesting is when we look at the current healthcare system in the UK, and sadly where we are in terms of corridor care in emergency departments, how can we monitor maybe 20 or 30 patients in an emergency department who are waiting in unmonitored spaces? And how do we predict early deterioration in that group? Um, so are there technologies out there that would allow us to put, as somebody comes into a hospital, hasn't got a monitored cubicle, monitoring devices on this patient that remotes and allows us to do early prediction by looking at where they're trending? Now, the other group, and probably much more into our point as an individual who visits emergency departments on occasions and it doesn't actually work in one, is when we talk about multi-casualty scenarios and that casualty clearing scenario. And actually where you've got an incident where the number of patients is overwhelming the ability to convey, how can we look at, in that scenario, using technology to help us triage the responders, the non-responders, those at risk of deterioration, those that have got subtle hemorrhage, and using that maybe for those 30 patients to work out how we prioritize movement. But I think one of the keys is once you get really good physiological data, and this is going beyond the kind of cardiac arrest patients, you can really start to think about how do we use that to predict deterioration.
So, Mark, when there is potential for maybe misunderstanding that data and misinterpretation, could I get you to speak to, some of the implications that can have on a resuscitation?
Absolutely. I think probably there's two bits of answers to this. And if we look firstly in the general effect, if we misinterpret our monitoring, if we miss a single blood pressure reading, that might be the only signal we get in a 5-minute cycle that something's gone on. So we miss that opportunity and that really responsive opportunity to think actually this is somebody who's not on an upward trend or not on a stable trend. We're missing that. I think when we start to look at the patients who I have a kind of academic interest in as our cardiac arrest patients, um, and we start thinking about this, and there's some really interesting. I heard a presentation recently from the team in Sydney who are doing some of their work around ECMO and Dr. Kurtz, and they are where they're turning up to potentially put ECMO onto these patients. They're putting arterial access in, therefore they have got the ability very early within their arrival to get an understanding of what's going on with the CPR. And the number of patients they're seeing where they haven't got good flow and good pressure, or good pressure and good flow, is quite remarkable. It's really quite scary. And it might start to help explain why, when we look at the RCTs around mechanical CPR, why the majority of these, and I'm very careful what I say because here is the majority of these have been neutral, is actually if we haven't got that device in exactly the right place for that patient, we may not actually be giving ourselves what is really good flow. And I think our experience in London, and we're nowhere near the numbers that they've done in Sydney, but early data of looking at this within the ECAT team in London is you turn up, you get arterial access, you tweak the chest compressions, and you see diastolic blood flows increase. And if you've not got that data, but I come back to the point we made earlier, doing that at minute 20 or 25 in the arrest may be too late. And we've got to think a way of doing this that's beyond arterial blood pressure monitoring. And we've then got to think about, well, if we know it's bad or it's not as good as it could be, what's the next step? And what do you do? How do you get it better? Can you protocolize what you might do with your chest compressions to create that? Is it that you think, well, we've not got great diastolic blood flow? Is it that we need to increase the depth, or do we need to decrease the depth? Is it we need to move our hand position slightly? Do we need to move our hand position to the left, slightly to the south? Now, all of this comes at a level of risk because part of the reason we do chest compressions over the sternum in the middle of the chest is it's relatively safe. And we know that the data around rib fractures and flails in standard resuscitation is high. We know that I think it's 6% of cardiac arrest patients have some level of intra-abdominal pathology, which is iatrogenic. And when we start moving our hands around, we may increase that risk. So we've got to do it. So not only do we need something that tells us what the flow is, we probably need to be able to some extent, think, what do I do now my flow's not good or my pressure's not good? Is it move the hand slightly south? Is it move the hand slightly lateral? Is it reduce the compression depth? And there is some great work going on around transesophageal echo. And some of the work going on in New York is absolutely blows your mind. And I was really privileged to attend a course run by Robbie Lendrum and others at Bart's, where we're starting to think about the use of transesophageal echo in cardiac arrest, because what you can do is put the echo probe down. And I say this like it's easy, it's got some skill, and then you can look at exactly where you are. Are you compressing the left ventricle? Are you over the aortic outflow tract? And with some reasonably simple things that Robbie and others even managed, I'm sure Scott even managed to teach me in a day, you can do this. But in order to put a transesophageal echo probe down, you need to have a patient who's intubated with a secure airway. You need what is a probe that is multiple tens of thousands of pounds. That is quite friable and quite easily broken. And all of us who've worked in pre-hospital care, if it's easily broken, it doesn't have a role in pre-hospital care. And so if you can do this perhaps by arterial monitoring, but you can perhaps use transesophageal echo. But neither of those are a sustainable method of doing physiological guided resuscitation across a workforce, across a population. What they may allow us to do is answer the questions about and what. I think they will tell us over the coming months and years, as we start to do more of this, is what are the things we might want to do when our pressure isn't as good as we would want it to be. And I think that's the really exciting thing now about using TOE, is not that I think it's a sustainable solution, is it might start to help us protocolize what's going on. And I think the kind of conversations that are going on around extracorporeal support are really helpful for this, because as we start to think about extracorporeal support in the small subset of patients where this might be benefit, we'll start to get some information that will benefit a lot wider group of patients. And you can invite me back. We've just got a paper in press at the moment, so you can invite myself and Rachel Fothergill back, and we'll talk to you about some of the numbers we've been looking at in London around patients who might benefit from an ECMO service, and the numbers there. And I won't ruin our paper by sharing our outcome data, but it's really interesting in terms of where does ECMO fit in a system, and is that ECMO needing to be delivered? Is there an option within the UK setting for rapid transfer? How do you deliver ECMO when you have got a small number of ECMO centres, all who happen to be within 3 miles of each other in central London, bar one? And how do you deliver that? Or is it that we actually need to move ECMO into the community? And we'll come perhaps some talk on a different day about that. But what this ECMO work is doing is allowing us to think about that physiology of resuscitation, because as you start to put the wires and the pumps on, you start to know what's going on in the chest. And I think that will help us answer some of the questions. And I guess where we now need to start thinking about is, if transesophageal echo or TOE isn't really a tool for pre-hospital care quite yet, and if arterial access might not be quite a tool that's sustainable across an entire workforce, what are the other things we could look at?
So my next question, Mark, really is around, so me and you both worked in London as advanced paramedics within the critical care program in London. One of the aspects of the advanced paramedic practice in critical care program was absolutely that on a daily basis you might see 2, 3, 4, 5, 6, up to 7 cardiac arrests a day. So you really having your feet held to the fire, and you're starting to be able to differentiate signal from noise. You're starting to really, in a way, hone your practice, and quite a lot of critical care practice around cardiac arrest was triangulation of not only in cardiac arrest but in critical care, was really around triangulation of diagnostics. So looking at what the echo or indeed what the ultrasound is saying, maybe subcostal or otherwise, looking at what the rhythm is, and also maybe looking what the ETCO2 is, to try and get a semblance. But to your point, it's not telling you about flow. It's not showing you flow. They are surrogate markers. Certainly, ETCO2 is a surrogate marker, but you're trying to get you're trying to get under the skin, and you're trying to really get a semblance of what the heart's doing, what the physiology is doing, what the tissues are doing, to understand where you're going. And it's this triangulation which I think is powerful. But to your point about adding more sensitive markers to that, could I just get you to maybe to go deeper on really, just really balancing, the acute physiological signals that are actually reliable, and triangulating all this data to give you almost this shared situation awareness, which you can then confer to the team, But yeah, and it is the basics. Well, it is that oxygenation. It is quality assuring the tubes in to mitigate hypoxia. It is, and it's all of these things. It might be decompressing the stomach if there's been excessive bag valve mass. It's meticulous attention to detail, then triangulation of these results. But could I get you to maybe go deeper on that, just to give us, because the goalposts are changing and we are getting a few more tools in the toolbox. But to your point, they really need to be able to, it's survivability and its outcome that really will be the success marker, I think.
So I think the first thing to say is virtually everything we're talking about is surrogate marker, because actually we don't know what coronary perfusion is, and we don't know what cerebral perfusion is in the main, and everything we look at is a surrogate marker. And we have historically talked about end-tidal CO2, and end-tidal CO2, I think, has a really useful place in pre-hospital care. It's rapid, it's quick, it's getting more rapid and more quick. Some of the newer technology where you don't need to even allow the machines to calibrate is absolutely great. And it is a really low invasive skill. But you've got to remember that actually what CO2, end-tidal CO2 is, it's a proxy marker. It's a combination of cellular metabolism, ventilation, and perfusion. And what you're looking at is all of those. And we all know that when you sit there and then when you have an arterial line in the patient and you can take an arterial sample and look at what their CO2 is, there is a gradient. There's an absolute gradient. And the sicker the patient is, the greater that gradient is. And I go back to you kind of all is link. And the more of this I've done over the years, the more of it you realize exactly how much and how difficult that gradient is to predict. And actually, I think there are some simple things that in the main, when you put a mechanical chest compression device on the patient, if that CO2 hasn't gone up, that mechanical chest compression device is not doing what you think it's doing, therefore change something. I think there are some things end-tidal CO2 absolutely helps us with. But we also know as the arrest progresses and you get cellular death, that end-tidal CO2s will start to decrease. We also know that there are lots of things that impact CO2. We know that a VQ mismatch will give you some very abnormal CO2 readings. We know that our VTE patients in cardiac arrest will often have a lower than expected end-tidal CO2. Some of our tamponade patients and our medical dissections will have a lot lower end-tidal CO2s than you would expect. Some of our hypovolemic patients will equally have that. So we've got to think about exactly what we're looking at and using what we've got available. Now, there is some really good, interesting work going on around near-infrared devices and using near-infrared devices to look at cerebral perfusion, near-infrared spectroscopy, NIRS. It's continuous, it's non-invasive, it actually reflects brain perfusion in the main. It's been used and it's got fairly extensive use now in critical care settings and particularly some pediatric critical care settings, but it isn't in direct measure. And actually, what we don't know is what good looks like with NIRS currently. What does a good NIRS look like in cardiac arrest? It's low tech. You can literally, it's stickers on somebody's head. Technology is probably not quite exactly portable enough to be where we'd want it to be for pre-hospital care, but it's not far off it. We've talked a bit about end-tidal CO2. And the next thing to probably talk about is non-invasive beat-by-beat blood pressure. And this is really exciting technology. I've been having a play with this. We've been putting this on some patients in cardiac arrest. It's a finger cuff. And everyone looks at you and goes, well, you're never going to get finger perfusion in cardiac arrest. Well, you can, is the answer to that. We're absolutely certain you can. It's continuous BP waveform. It's non-invasive. And interestingly, if you can get it to calibrate, you've got effectively a beat-by-beat perfusion marker in cardiac arrest. I think it's really exciting. I think this has absolutely something that we could use in cardiac arrest patients. It's yet to be really validated in cardiac arrest, and there is a low flow thing we need to have a think about and how we get that to work. But this technology in terms of a beat by beat And there's good evidence now. If you read the literature on kind of non-invasive beat by beat blood pressure, really good evidence outside the cardiac arrest patients in being able to risk assess early deterioration, looking at all of the stuff we know that you can get from an arterial trace about changes in patients and deterioration. I think it's really interesting. And I think it may have a role in cardiac arrest, and it's quick and easy to do it. It's literally putting a cuff on somebody's finger. There are other things. There is some really interesting tech coming out about central oxygen saturation monitoring. So putting a SATS probe into somebody's ear and looking at whether you can use that and as a very rapid marker of flow. Because actually, if you've got a plethora wave or plethysmographic wave, you've probably got some level of flow. And what it probably is telling you is around cerebral flow, maybe less so about a coronary flow. And if you do it centrally, you've probably got a more stable signal. It's early days, but this tech is really interesting. And I think what we've now got to start doing is using our systems where we're delivering invasive acute care with teams to then start to validate some of the technology. Because in the world of Mark, and that's a very scary place for anyone who knows me, is what you really want is something that's as simple and as easy to use as it becomes part of the AED. Is this an AED that's got a NIRS built into it? Is it an AED that's got a central saturation probe? Is it an AED that's got a beat by beat blood pressure cuff built into it? So you stick it on the patient whilst you're putting the pads on, doing chest compressions, taking no more than a few seconds to apply. And then the AED, through some intelligent learning, and this isn't AI, this is just protocolized learning, says to you, well, I don't think your compressions are good enough. I'd like you to move your hand position, move your hands a bit further south, ease back a bit on the compressions, make sure you're not over the left ventricular outflow tract by moving your hands a bit laterally. And actually, you could really get to a point of really being able to individualize the resuscitation so early that it would be able to make a difference for patients. And that's the key. You've got to move this out of the world. And I say this as an individual now in a HEM service. You've got to move this out of the world of a specialist pre-hospital critical care service. Even in London, I'm not convinced the sustainability of this and the viability for patients is about advanced paramedics putting arterial lines into patients. I'm convinced it's the right thing for us to be able to do. And there's no reason a paramedic shouldn't be able to do this, and they do it around the rest of the world. But if we want to make a difference in patients in cardiac arrest, it's got to be non-invasive and it's got to be much earlier in that patient's progression. Because I think that's what will start to allow us to target our resuscitation to an individual's physiology. And let's be completely honest, we're all different shapes and sizes. And I'm pretty convinced that what might work for Owen's chest compressions might not be the same that works for Mark's chest compressions. And if we guide every other bit of medicine based on a physiological approach to resuscitation, why aren't we doing this in CPR?
Yeah, indeed. No, indeed. And I wholeheartedly agree, actually. Just as we come into land, a couple more questions, Mark. One would be around data and data handshakes. Historically, and this has maybe been the bane of your life, both as a clinician, but also as a researcher, is sometimes when you put a different monitor on, there is no data handshake and or open API to share data. So actually, from the patient consultation, from the pre-hospital phase to the in-hospital phase, especially if it's a good outcome, there's no, and or otherwise, in that clinical governance case, the continuity of data and the data sovereignty from a monitor and a service is not there. Could I get you to maybe speak to really, just the how we start to build systems where we can really garner the data and indeed the audit from the entire patient journey and indeed how because that can influence how we approach future resuscitations. If we can start to see trended data over time, if we can see the continuity of data from that whole patient journey, and it can start to inform from robust audits, how we meticulously approach a resuscitation effort. Could I get you to speak to that?
Absolutely. And I think we have to start with low tech stuff. And I'm going to quote a phrase from Matthew Said in his book, Black Box Thinking. If we don't know the outcome of our decision, it's like playing golf in the dark. And that's the entire basis of ambulance practice. And I've spent many, many years now working with others, with David Davis, with others at London, about how do we have really robust clinical feedback systems to allow paramedics to understand what the outcome of their decision. And that's exactly the same as what we're talking about here, is if we're not collecting the data in a grown up, joined up systems approach, we actually don't know what we're looking at. It goes beyond that, is actually then how do we turn that data into something that's interpretable at handover? And some of the work that the team at Bart's looking at with the AI trips work, and all of the guys doing that, and Zane Perkins's work doing this, and others, is how do we, in the trauma patients, use that data to inform incoming care? And how do we do that smartly? Because in a really busy emergency department, perhaps when there are 3 or 4 trauma patients in the resuscitation room, can we use large language models, large data sets to actually flag that actually the data for this patient who's on their way in shows a level of risk that perhaps that isn't there for some of the other patients. So we probably need to have a think about how we do that. And when and where we should do that, because just flowing data right routinely into emergency departments who might be seeing 100, 150 ambulance patients in a 24-hour period probably is meaningless, because nobody's actually got the time or the space to look at that data. So actually, how do we use technology to garner that data and turn that data into something that's clinically interpretable? So when we look at the data in terms of chest compressions, we should ask ourselves, and what? So we can move our hands around the chest, we can try and optimize chest compressions. We then move on to actually, does this patient have a role for targeted vasopressors? Is that adrenaline? Is that another vasopressor? And targeting that towards a physiological endpoint? Or is it perhaps that we should look at the work that's been going on in Norway and in East Anglia around mechanical, effectively mechanical adrenaline? So putting a balloon into the aorta. Reboa has lost favour in trauma, some of the kind of work from PPRO and others and all of that. And the Reboa studies have said, interestingly in trauma, but does it have a role in cardiac arrest? Could we use it as a mechanical flow inducer? Can we put that device in and target coronary and cerebral blood flow in those first minutes of cardiac arrest? But arterial access into the groin, putting a balloon in, is not an easy skill. It's certainly not a skill that's achievable. But actually, the question is, if you need to do that with a balloon, could you do it with an abdominal tourniquet? Could you put a mechanical obstruction onto the abdomen where you are getting suboptimal resuscitation to promote coronary and cerebral blood flow? So there's lots of stuff you can use as an endpoint for this, and really exciting stuff going on about how we could look at a physiological guided approach to CPR.
Yeah, listen, that's fantastic, Mark. Fantastic. And just to come back, just finally to a final question, something you mentioned earlier, which I think is absolutely true. It's that actually any robust intervention, or indeed not even intervention, but just monitoring, which will enable us to deliver better care, should be delivered to the masses. And absolutely having something which integrates and or syncs with the defibrillator, which can speak to a defibrillator. And maybe is even part of the defibrillator package. It's not just a critical care asset, because survivability shouldn't just lie just with the specialist team. It really is. It's enabling and empowering and democratization really of those tools to the wider workforce. Could I get you to speak to, really, as we come into land, because the trajectory of focus and perspective seems to be shifting towards flow, understandably, and certainly, as you were saying, diastolic blood pressure and coronary flow. Could I get you to speak to, really, something just listeners could take away from this? How should clinicians think slightly differently about, how they approach critical decision making in resuscitation when looking at a monitor?
So I think you're absolutely right. And our challenge with this has to be that if we want to see this as a kind of sustainable population-based intervention, we've got to think about moving it out of the critical care setting, and we've got to use the critical care settings to test our hypothesis. Do that through a proper evidence-based approach. Really challenge ourselves about what of this could we move, because actually, if your chest compressions are suboptimal for 10 minutes. All of the data tells us at that point the survivability is gone. We know that in systems we work in, an 8 to 10 minute response time in cardiac arrest is not unusual. We've got to move this into the world of public access defibrillator technology, getting this really key to the patient, close to the patient. We've probably got to build this into mechanical CPR devices so that actually we've got something that tells us that that device is completely usable. But I think where we are right now, what we have to do is think about the stuff we've got available. We've got to make sure that all we know currently is what the guidelines are telling us, which is actually we should be really concentrating on high quality resuscitation. We should be doing all of that stuff we know makes a difference, because that's what the evidence currently tells us, which is really good high quality resuscitation, minimal interruptions, minimum time off the chest. High quality CPR, rotating the operator around that process and focusing on that. We should absolutely challenge ourselves on the monitoring we've got as pre-hospital care providers in terms of end-tidal CO2. I come back to the point we made earlier that actually if you put a mechanical device on, the end-tidal CO2 doesn't go up. Perhaps that device isn't in the right place. We should be absolutely focused on making sure when we're applying any device, be that defibrillator pads, be that mechanical chest compression device, it's applied optimally. I am bored of telling people to make sure they secure their mechanical chest compression devices, mark on the chest where it is so you know if it's migrated. Look for things that we know that we can look at right now. Femoral pulses is not an unhelpful measure. And then actually really engage as a system with what I think will become the emerging area of evidence about how do we guide this resuscitation physiologically. And actually when an enhanced care team turn up for those who don't work in those, is focus is actually, and I say this all the time, is your focus is on gaining ROSC. We're going to fiddle around the edges, but what we're probably fiddling with is not going to make a difference. You're doing the essentials, and it's the essentials. And a colleague of ours, Dr. Neil Thompson, once said to me, we need to stop calling it basic life support and start calling it essential life support, because that's probably what it is.
Yeah, it's powerful. It's a powerful pivot actually, and it's a great place to finish. And just to your point, it really is. It's fantastic to see. You're just about to publish this evidence. We're going to have you back on the podcast to review really where the future of ECMO, because for a subset of patients, maybe that is the right pivot. But does it sit in a specialist centre? Does it sit in pre-hospital care? So we'll get yourself and Dr. Rachel Fothergill back on to unpack that research piece, because again that's a piece of the jigsaw for a subset of patients in cardiac arrest or post cardiac arrest. Mark, it's always a pleasure to have you on, it's always a pleasure just to really unpack your perspective on these topics. So listen, thank you so much.
Owen, thank you very much, and thank you for having me, and thank you for those who've listened and putting up with my ranting on the subject.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.